Good afternoon, everyone. Okay, good afternoon, everyone. My name is Andi Ade from Jakarta, Indonesia. I am responsible for ASPA PPSIG education. Allow me to welcome you all to the first ASPA PPSIG webinar series. And to know further about ASPA PPSIG, please welcome Dr. Angela Yo. She's the chairman of ASPA PPSIG. Angela, the screen is yours.
Thanks, Adi. Okay, hi, welcome everybody. Welcome to the inaugural session of the ASPA Pediatric Pain Special Interest Group webinar series. Today we've got an exciting lineup for you from our very esteemed Japanese speakers. What we're going to do is, before I hand the floor over to Dr. Yutaro, who's going to be our moderator today and who's going to explain everything and introduce everyone proper, I'd like to tell you a little bit more about what we do in the Pediatric Pain Special Interest Group. So basically, the Pediatric Pain Interest Group was born out of a community of like-minded individuals who felt that pediatric pain was not well managed in the Asian region in general, and who really wanted to advocate for better management. So with our SIG, we do have a mission and a vision. Our mission would be to increase awareness of pediatric pain, its assessment and management throughout Asia, through outreach and education, and to establish an international network of resources to support this mission. And our vision then would be Asia-wide excellence in pediatric pain management, where no child is left in pain due to ignorance, no want. And so we created this special interest group with the aims of meeting that mission and our vision. And the membership benefits, as you can see here, are really quite worthy of consideration. We do have a fairly global regional network of specialists on board, and we always encourage more networking and opportunities to work with each other. Like, for example, today when we've got a very esteemed Japanese crowd speaking to us, so I'm very excited about that. We also do have an online notice board where we post up the latest webinars, seminars, as well as training opportunities for yourselves and for perhaps your team or your juniors. We do also provide free educational resources for doctors, nurses, other healthcare workers, patients, as well as parents of our patients. And we do try to create more opportunities to collaborate and research together. Next slide, please. Thank you. So this is an example of what we did in 2022. September is Pain Awareness Month, and so we sent this out to our members for everyone to kind of use in your own institutions, either for a teaching purpose or as for sort of an educational purpose. Just a short sort of poster like that, so it can be printed out, or it can be shared out amongst your colleagues, particularly for those who are not well aware, for example, on how to manage pain or assess pain. So this is one of the examples of things that we do within our group to try to facilitate an improvement in pain management throughout Asia. Next slide, please. Thank you. So as later on you'll find out, we do have more things planned in this quarterly webinar series. Save your dates for the 8th of April, because we are going to talk about something that many of you have fed back about during the ASPA Flex series. And so your feedback is actually very important because it helps us plan what sort of talks regarding pain you guys all want to listen to. All right, so I think without further ado, this is my final slide. If you're interested in joining us, please contact us via email or scan the QR code. We are a body housed under ASPA, and we look forward to meeting more of you and making pediatric pain a thing of the past. All right, thank you.
Thank you very much, Angela. So without further ado, please welcome Dr. Yutaro Funahasi. Dr. Yutaro will be our moderator for this afternoon. Dr. Yutaro is the anesthesiologist from Department of Anesthesia and Intensive Care Unit, Sendai Kosei Hospital in Sendai, Miyagi, Japan. Dr. Yutaro, the screen is yours.
Hello. Can you see me? Hello,
Yes,
everyone.
clearly.
And welcome to the first webinar of the Pediatric Pain Special Interest Group. The topic for today's webinar is neurobiology of pain in children. In the next 1 hour and 30 minutes, we hope to have our panel of experts share with you the knowledge of pediatric pain pathways and management of chronic pain. I am Dr. Yutaro, fellow with the Department of Anesthesia and Intensive Care Unit in Sendai Kosei Hospital in Japan. I am the moderator for today's webinar. Before we start the webinar, I will share some housekeeping instructions. If you have any questions or comments for the speakers, you may post your questions and comments in the Q&A section. Please note that the chat and raise hand function have been disabled. Your question in the Q&A section will either be answered directly within the Q&A section or would be taken live by the speakers at the end of the talk. During the course of the talks, poll sections may be posted. When a poll is launched, you have 30 seconds to respond and submit your answer. The answers to the poll questions will be shared once the polling is closed. Okay, without further delay, let me introduce our first speaker, Dr. Zitu Kato. He is the chair of the Department of Pain Clinic in Kaskabe Medical Center in Japan. He is also clinical professor of the Department of Anesthesiology in Nihon University School of Medicine. He is one of the leading pediatric pain clinicians in Japan. I am very looking forward to listening to today's lecture. His talk today is titled Pain Pathways in Children, Need for Active Pain Prevention and Pain Management. For the first poll section, we would like to ask you 2 questions. Question 1, which of the following is not a component of pain? Sensation, emotion, cognition, and development. Okay, so about 70% of the audience selected development. Okay, next. Question 2. Which of the following is an incorrect mechanism by which a child's experience of pain does not end at that time? Central sensitization, fear, depression, memory. Okay. So about 40% of the audience chose central sensitization or depression. Okay. The answers are in the presentation, so please look forward to the talk. Let us now welcome Dr. Zitu Kato.
Hello, everyone. I'm Ajit Scotto, currently working as a pain clinician, anesthesiologist, and palliative care physician across all age in Japan. First of all, I'm so grateful for the opportunity to be an invited speaker at the ASPA webinar series. Today, I'm going to talk about pain pathways in children, need for active pain prevention and pain management, in order to inform pediatric anesthesiologists to know characteristics of pediatric pain in detail. In terms of disclosure, there are no conflicts of interest. This is an introduction slide of Cascabe City, where I work. The city may be known worldwide as the city of manga, Crayon Shinchan. It is located in the northeastern part of Saitan Prefecture, north of Tokyo, as you can see. This is Cascabe Medical Center. It was about 350 beds, and we have just started an outpatient pain clinic and palliative care clinic in June of last year. This slide provides overview of today's my presentation. First, pain transmission and pain inhibitory systems. Second, children are more sensitive to noxious stimulus than adults. Third, the pain experience doesn't end at that time. Finally, online learning site on pediatric pain. Now let's start the first section of pain transmission and pain inhibitory systems. This figure shows the path from the excitation of nociceptors to the creation of pain in the brain. Excitement of nociceptors is initiated by a nociceptive stimulus. When nociceptors are excited, their signals are transmitted to the spinal cord through A delta and C fibers. In addition, there are two projection pathways from the spinal cord to the brain. One is yellow pathway from thalamus to cortex, which is indicated as yellow arrow. The other is green pathway from parabrachial nucleus to amygdala, which is indicated as green arrow. And then pain is generated through the pain network, which is excited by pain-related neurons. It is important to know the mechanism of how pain is produced to understand children who complain of pain. In addition to pain transmission system, our body has a system that inhibits nociception, called descending pain inhibitory system. As shown in the figure, when the nociceptors are excited, for example, 3 arrows are produced and input to the spinal cord. At that time, the descending pain inhibitory system is automatically activated and the 3 arrows become one, a mechanism that protects the brain. Now let's take a look at the definition of pain here. In 2020, the definition of pain was revised by ASPA in 41 years, as you can see. There are 2 major changes in this revision. One is the word described has been removed. This was due to the judgment that infants feel pain without expressing it in words, and that people diagnosed with dementia are unable to speak even if they feel pain. The other is the addition of new phrasing, which is resembling, that associated with actual or from potential tissue damage shown in red. This phrase is reflecting the new evidence for nociplastic pain. It's also called the third pain in addition to nociceptive and neuropathic pain using the classification of the pain mechanism. Therefore, based on the definition of pain, we have created a figure that shows the three specific components such as sensory, emotion, cognition, and modifiers in assessing pain in children who complain of pain. Now, I'm going to move the second section of children who are more sensitive to noxious stimulus than adults. Until about 40 years ago, most physicians believed that neonates did not feel pain based on incorrect textbooks information. Actually, when I became a physician in 1983, I still remember being taught by professor that neonate does not feel pain. The slide here shows two typical descriptions that were in the background. One is Charles Darwin's writing. Even though newborns exhibit pain reactions, these are only reflexive and babies were incapable of experiencing and expressing true pain. The other is a writing in a typical textbook of the time. Let me show you recommended anesthetics during general anesthesia for neonates at that time. In contrast to adults, analgesics were not recommended for neonates. Anesthesiologists were too concerned not only that neonates do not feel pain, but also that analgesics such as opioids can suppress the circulatory and respiratory systems. Meanwhile, in the early 1980s, a lot of evidence indicated that neonates felt pain, as shown in the slide. In the field of basic research, the new findings that it is not the meninges that is immature, but the descending pain inhibitory system reveal that the error of common knowledge at that time. As a result, two new evidence were identified. One is neural mechanism capable of reacting to tissue are clearly present. The other is neonate is more sensitive to nociceptive stimuli than adults. The slide shows that pain transmission system during the immature of the descending pain inhibitory system. As you can see, the nociceptive signals that are reduced in adults reach the brain without being reduction in neonates. For that reason, neonates need more protecting from uncomfortable noxious stimulus than adults. Consequently, in 1987, a statement was finally released by the neonate societies related to neonate as shown on the slide. Appropriate use of analgesics during surgery and procedures was recommended for neonate as well as adults. However, despite this 1987 statement, as shown on the slide, we are still a long way from achieving appropriate pain management for neonates. Now is the time for us healthcare providers to apply this knowledge into practice. Let's move on to the third section of the pain experience doesn't end at the time. Let me show you the interesting paper indicated that the pain experience does not end at that time. The study investigated pain reactions during subsequent vaccination for children who had undergone neonatal circumcision and those who had not. Circumcised infants showed a stronger pain response to subsequent routine vaccination than uncircumcised infants. Among the circumcised group, preoperative treatment with EMRA, which means topical lidocaine pilocaine cream, reduced the pain response to vaccination. Therefore, authors recommend anesthesia to prevent neonatal circumcision pain. Let's think about what is happening in the body of an infant receiving circumcision at the following vaccination. The implication of this result is that the neonates underwent circumcision while their descending pain inhibitory system was still immature, so that nociceptive stimuli could have caused sensitization and neuroplasticity may already have occurred prior to vaccination. Or thus, it was suggested that the use of anesthesia during circumcision could prevent them. Let me present the basic research results of Professor Fitzgerald that support this. So far, animal studies have reported the 4 factors to be related shown on the slide. First, the importance of neural activity from the original injury site. Second, sprouting and sensitization of peripheral nociceptors. Third, increased sensitivity of dorsal form nociceptor circuits. And the role of neuroimmune activation, for example, its microglial reactivity due to re-injury. This is a figure created by the authors. I think it helps to understand where these 4 factors happened. Next, I will present the study indicated that functional abdominal pain experience in childhood influences the frequency of chronic pain in adulthood. Let's have a look at the table. The prevalence of each pain site in adulthood is shown. Look at the headache in the upper left corner. Interestingly, the prevalence of headache in adults is 4.4% for controls without abdominal pain in childhood, 20.6% for resolved, and 31.4% for unresolved. That is, youth with abdominal functional pain may be at increased risk of chronic pain and headache in adulthood. Numerous studies have shown that neonate pain experience affect infant pain reactions, infant pain experience affect child pain reactions, and child pain experience affect adult pain reactions, and so on, as shown in the figure. These mechanisms are complicated by central sensitization by the sensory component, fear and anxiety as the emotional component, and memory of pain experiences as the cognitive component, as shown on the slide. Based on this information, when treating children who are suffering from pain, getting information about past pain experiences, in addition to focusing on the current pain, may lead to appropriate pain management and pain relief. We present here the already recommended methods of preventing pain associated with medical procedures during vaccination. In 2015, WHO published a position paper on how to reduce pain during immunization. Background is shown on the slide. Vaccine injection can be a source of iatrogenic pain. Pain management is a human right. It provides information how to reduce pain, distress, and fear across all age. This paper cites Canadian guidelines. It is an evidence-based 5P approach, as you can see: procedure, physical, pharmacologic, process, and psychological. Except for pharmacological methods, all of these methods can be used immediately in daily clinical practice. Finally, I would like to introduce you to an online site for learning about pediatric pain. Two free online sites are described in this paper. One is Sick Kids Canada's online pediatric pain education curriculum. The other is a curriculum from the Royal College of Pediatric in Child Health, United Kingdom. This is a detail of the Sick Kids curriculum that I also learned. The system was designed to help people learn new knowledge in a quiz format. I would recommend the use of this online site. This is an easy way to get a new information you don't know using it. In conclusion, if healthcare providers know the characteristics of children's pain based on evidence and can practice pain prevention and pain treatment, it is clear that they can reduce pain, suffering, and fear associated with medical procedures for children. That's all. Thank you very much for your attention.
Thank you for your presentation, Dr. Zitu. I have heard that Crayon Shinchan is widely popular in Asia. We have learned about the differences between children and adults in pain pathways, and that pain is not a temporary problem, but can cascade as central sensitization and memories of anxiety and fear. Q&A section for this presentation will be summarized after the second presentation. If you have any questions or comments for the speaker, you may post your questions and comments in the Q&A section. Without any delay, now I'd like to introduce the next speaker. Dr. Ayuko Igarashi. She is the chief of the Department of Anesthesia in Miyagi Children's Hospital in Japan. She is working not only as a pediatric anesthesiologist, but also in practice of chronic pain treatment. I am very looking forward to listening to her today's lecture. Her talk today is titled Neurobiology of Chronic Pain. How does simple pain turn into chronic pain? For the second poll section, we would like to ask you two questions. Question 1. What is the percentage of pediatric population who suffer from chronic pain worldwide? Less than 3%, 10%, 20%, 50%. Okay. So about 40% of the audience selected 20%. Question 2. A 10-year-old girl twisted her ankle. Her exam showed no sign of fracture and she was prescribed ibuprofen. 3 months later, she complains her foot pain is getting worse and now spreads to both of her legs and hips. She is now on wheelchair. What do you recommend as a treatment of her pain? Nerve blocks, opioids, consultation with a psychiatric doctor, rehabilitation.
Oh. Oops.
Okay, about 50% of audience selected rehabilitation. The answers
Sorry,
are
Yuko.
okay.
Sorry, there's something wrong with my computer. I tried to reopen my PowerPoint slide. So
I think you are in your
just
last
give me
slide,
some
Dr.
minutes.
Ayuko.
Yeah, it didn't work out well. So let me find my slide. Somehow it's diminished. What is that? Files, the basic files from Microsoft. No. Oh, okay. Looks like it's here. This one. Gosh. Ooh. Sorry. Oops. Sorry, it's not working. What can I do?
You can actually, you are on your
Yeah,
last
I
slide,
have
Dr.
my
need to move
presentation
it.
on my desktop, but I cannot find it in the shared slide folder. That is a problem. Can't find it.
You need to end your previous presentation, the one that we
Okay.
Dr. Aiko,
Yes.
I will share your slides. Okay.
Yeah, but can you do that? I would try it once more. Okay.
Okay.
Okay. Because no, I can't find it. So please. Sorry.
Okay. I will share your slide.
Works very fine, but now it's not. So please start the slide, and I will probably ask you to click to move on. Okay. Could you
Okay.
do that for me?
Okay.
I'm so sorry. Okay.
Can you see?
No, I can't. Yes, I can now. I can. Okay.
Okay.
Can I stop? Can I start now?
Okay.
Okay. Okay. Thank you. Sorry for the delay, and thank you for all the ASPA interest group member to giving me this opportunity to talk about chronic pain in children. And it's Yuto said in his presentation, I am a pediatric anesthesiologist working in a small children's hospital located in the northeast of Japan, which is shown on this slide. And I also work in my hospital as a palliative care team doctor and treat children with chronic and complicated history of pain. Today, I'm going to talk about chronic pain in children and how simple pain turns into chronic and rather complicated one. And there are actually, sorry, move back to, yes, there are lots of extensive studies in this pain field, but I am not a researcher. So today I'm going to talk about the difference between acute and chronic pain and how they, how the transformation of the two kinds of pain actually take place. Also, from a perspective of a clinician, I'd like to talk about what we should keep in mind when we treat patients with chronic pain. Please move on to next slide, please. Thank you. This is a very cute picture of snow monkey. I love this picture. I think he's waiting because he has some kind of pain problem, like many Japanese who visit onsen, hot springs for the same purpose. As shown in this slide, many people in Japan suffer some form of chronic pain. Because number is so many, pain clinic doctor cannot deal with all of the patient. So many people instead seek helps in alternative medicine like shiatsu, acupuncture, or hot spring like this monkey does. And I actually think that he made the right choice for his treatment, but I will explain to you later in this presentation. The next one, please. Yes. Not only in Japan, but chronic pain is really a global health issue. It is really regardless of patient background or age. So 20% of adults globally suffer from chronic pain, and it's really regardless of their background or age. So as well as adult patients, children are affected too. Next one, please. So let's see, let's move on and see closely how pain affects pediatric population. About 20 to 35% of pediatric population are affected by chronic pain, and 10% of hospitalized children show some features of chronic pain. And 3% of pediatric chronic pain patients require intensive rehabilitation before recovery. And 70% of adult chronic pain patients record a history of chronic pain in their childhood. And 80% said that the pain in their childhood had never actually left them. So it's continuous. So one thing is that the chronic pain is not uncommon in pediatric population. And second thing is that if you see a child with persistent pain, maybe the child has increased risk of having pain as adult. So you cannot tell the child or the parent that the pain is just a temporary issue and it will go away sometime soon, because it may not. Next slide, please. Next one, please, Yutaro. Yes. So we can agree that preventing the development of chronic pain is quite important for children, their family, and the children's future. But what is actually chronic pain? What is the difference between chronic pain and acute pain? We are anesthesiologists, so we are very familiar with the treatment of acute pain. But what about chronic pain? So let's move on and learn about chronic pain. Next slide, please. Yeah, this slide shows the difference between acute pain and chronic pain. Acute pain has mostly specific onset and causes like surgery or injury, but chronic pain do not have specific onset, or even it has, it's quite a minor injury most of the time. And acute pain subsides when tissue heals, but chronic pain outlasts tissue healing, and actually it's continued for months or even years. Acute pain is a physiological response against tissue injury. So it must promote autonomic and immune response and enhance tissue healings. But chronic pain is actually unrelated to tissue injury. Chronic pain itself is a problem and causes lots of negative effects on patient, such as delayed recovery, low physical and social activities, and depression. We call chronic pain also as pathological pain. So imagine chronic pain is a broken alarm clock. We don't know how to turn it off while it keeps ringing. Next slide, please. So to understand chronic pain, we start from here. We start to understand how we sense pain. If we get tissue injury like small cut on the fingertips, local nociceptive receptors start to pick up the stimuli. And two kinds of neuron actually transmit the signal to the spinal cord. One is A delta fiber, which conducts fast and sharp and localized pain. And another is C fiber, which conducts slow and ambiguous kind of pain. And actually, C fiber plays a very great role in the formation of chronic pain. Both neurons end at the dorsal horn of the spinal cord. And here, the neuron switch to the second order neuron, and the second order neuron transmits the signal to brainstem or thalamus. And there, the third order neuron take the job and transmit the signal to sensory cortex. And at last, at this point, we sense pain. And also, tissue injury provokes an immune response as well as autonomic response. So pain is basically a very adaptive mechanism in our body and quite a useful signal to keep us from danger. Without pain, we would be in a big trouble, like a patient is shown on this slide. He is a CIP patient and he doesn't feel any pain. So these patients do not feel pain, so they have multiple injury from very young ages, and their life expectancy is not very long. Next slide, please. Yes, so pain is quite useful to survival, but sensing too much pain is not only unpleasant, but very disturbing to our activities. So we have a system to modulate the sense of pain. The right side of the slide shows the flow of the neurotransmission of noxious stimuli from peripheral to the higher brain level. It is called ascending pathway. And the right side of the flow, there are lots of inflammatory mediators such as prostaglandin or neuropeptides such as substance P or neurotransmitters. And they are all working on the each level to modulate the sense and transmission of pain. And also, brain itself has a system to modulate the sense of pain. This is called descending inhibitory pathway. And as you can tell from its name, it's mostly reduced the neurotransmission or the sensitivity to the pain. And besides this inhibitory pathway, our brain has another system because sensory cortex is closely connected to other regions of our brain. Our brain itself has a capability to distract our attention from pain, for example, through exercises or listening to relaxing music. So next slide, please. So pain subsides when tissue heals. But in case of chronic pain patient, the system doesn't work this way. As we get too much damage, please click the slide, please. Yes, if we have too much tissue damage, or for example, infection of the local site, and lots of inflammatory mediators are released, as well as substance P. And those mediators and the substance P increase the excitability of receptors. So the hypersensitivity of neural receptors and also neuroplastic change of the peripheral neurons are induced. Click the slide, please. So receptors start to sense at multiple kinds of stimuli, which is called peripheral sensitization. Please click, please. Yes. So this is called peripheral sensitization. And actually, in the spinal cord level, NMDA receptor, which remains relatively unresponsive during the phase of acute pain, start to responding to glutamate. So click the slide, please. Yes, so the peripheral neuron as well as spinal cord transmit more and more signal to the higher brain. And one more click, please. Yes, so also we are going to in this situation there are some neuroplastic change happening in our central nervous system as well. the atrophy and the decrease of the number of the neuron in the inhibitory pathway is reported, as well as the size of the volume of the brain itself decreases. So we start to feel pain when, which is proportional to the size of injury or unrelated to pain, even when there's no tissue injury, which is called central sensitization. Click, please. In this stage, patients start to feel abnormal sense of pain, like algenia or hyperalgesia. So in this situation, the usual remedy for acute pain is not working well. The next slide, please. Yes, so what is happening now is a change of the brain. So the chronic pain induced the neuroplastic change both in central nervous system as well as the peripheral nervous system as well. So the treatment for chronic pain is a little bit different from acute pain. Please move on. Yes, this shows the treatment algorithm for both acute and chronic pain. If you look at this slide, the two kind of pain algorithms are totally upside down. For acute pain, the first line of treatment is regional nerve blocks or opioid or some painkillers. But same strategy doesn't work in case of chronic pain. If you prescribe opioid to chronic pain patient, probably they require more and more opioid without seeing much improvement. So what is the treatment of choice? The first line of treatment for chronic pain patient is non-pharmacological treatment, such as CBT, rehabilitation, acupuncture, or maybe hospital, like the monkey in the first slide. As you know, this kind of treatment takes time. It takes sometimes weeks or even months before we see some improvement. So what is the remedy for chronic pain? Please click. Yes, actually, I think there is no clear boundary between two kinds of pain. There is some transitional stage. And actually, recent study shows that the pain communication process starts much earlier than we had previously thought. It is probably started shortly after the injury time. So the best way to treat chronic pain or prevent chronic pain is to start pain treatment as soon as possible. Next slide, please. We see some interesting phenomenon in children. We call it acute pain and chronic pain. Many children with underlying conditions such as inflammatory bowel disease or rheumatoid arthritis experience chronic or on and off type of abdominal or joint pain all the time. And if they undergo surgery, they will experience chronic pain and acute pain simultaneously. So what will happen to them? The chances are that their peripheral and central nervous system might have been already sensitized, and the neural hyperresponsiveness to painful stimuli have been induced. So their pain may be more severe than the other kid without this condition, or their pain may be prolonged or treatment resistant. Next slide, please. Another interesting about children in pain is that not all children develop chronic pain. As we observe in our daily practice, most of the children are quite resilient against surgery or the pain. They recover from surgery very quickly compared to adults. But not all the children are not that lucky. About 20% of them develop persistent pain after surgery, and their recovery are usually delayed. What is the risk factor? What makes the difference between two groups? The risk factor may be the size of injury or the nerve damage, or simply the severe and poorly treated post-operative or post-trauma pain. Or, as I said in the previous slide, the precondition with coexisting health condition and pain may be the risk factor. Next slide, please. But there are more, because the pain is very brain-related experience. Social psychological factors should not be ignored. Children need the parental support all the time, and parents need social support as well. So without ones, they are very isolated and they are helpless. And for example, low school education or low school attendance mean that the children do not have the support from their peers or their teachers. Lack of coping strategies or catastrophic thinkings are reported as risk factors for chronic pain. And somehow chronic pain patients are very depressive all the time. And in case of adult chronic pain patient, the female gender is reported to be a significant risk factor, but we don't know much about small children. And about genetical or cultural background, we need more data to say anything concrete. But one thing is clear, we humans are very emotional and social animals. So to deal with chronic pain patient, social and psychological factors are really key. Next slide, please. So imagine chronic pain as a pancake in this slide. It has multiple layers like biological processes, underlying health issues, and social psychological factors as well. And click here, please. And please click, yes. And in case of children, you have to think about their parent issues and family dynamics as well. So those issues are like dripping cream from the top and covering whole pancake. So you can imagine eating this pancake is very difficult. And so is the treatment of chronic pain as well. Please, next slide. But we have to tackle this problem and solve it because chronic pain triggers a lot of trouble in the future of children. Children with chronic pain may be at the risk of psychosocial problems like missing school, low academic achievement, low physical activity, withdrawal from social life, or interaction with peers. They have sleep disorder. They are depressive, they are anxious, and they are fearful of pain all the time. And more than that, they have increased chance of developing pain and psychological disorder in adult life. Even some of them become suicidal. So we really break this cycle and push the children back to their normal life. Next slide, please. So we are anesthesiologists. So what can we do as a starter? Maybe we can provide them preemptive analgesia or surgery, careful tissue handling like less invasive surgery, and good quality pain control after surgery or after trauma. Fortunately, we have lots of pharmacological agents available now for children. So make yourself familiar with these drugs and the usage of them, and also as well as side effects. Next slide, please. And another important thing is a vigilance. We should identify patient at risk. And if you spot one, prepare them and their parent about pain and the painful procedure. And if you spot children in pain, whose pain is more severe than the others, please check their medical history. There may be children with special needs for pain treatment. And also acknowledge the fact that the pain sometimes doesn't go away so easily. Pain sometimes stays. And it's not doctor's fault or patient's fault. Just give them a good support and good treatment. Next slide, please. So this is the end of my talk. This is a summary. Chronic pain in childhood negatively affects children's school lives, social activities, and increase the lack of chronic pain in adulthood. Pain causes structural and functional neuroplastic change in central and peripheral nervous system, and the imbalance between the modulation systems leads to chronic pain. Prevention and carefree plan management of acute pain and early recognition of pathological pain is a key for treatment and prevention of chronic pain. Thank you, and sorry for the inconvenience of this slide. Thank you, Yutaro.
Thank you, Dr. Aiko. Please wait. We were able to learn about the mechanism of acute and chronic pain and practical management. Thank you. So, now let us move on to the Q&A section and panel discussion. In addition to our invited speakers, we also have a guest panelist today. Dr. Andy Ade Ramlan. She is an assistant professor with the Department of Anesthesiology and Intensive Care in University of Indonesia. She also handles IT support today. Hi, Dr. Ade.
Hi, Yutaro.
Thanks for the IT support today. And Dr. Anuradha G. She is an assistant professor with the Department of Pediatric Anesthesia in Indira Gandhi Institute of Child Health. Hi, Dr. Anu.
Hi, Dr. Yutaro.
Let us know your opinion later. And Dr. Angela Yeo, the president of this Pediatric Pain Special Interest Group. She is a senior consultant in KK Women's and Children's Hospital in Singapore. Hi, Dr. Angela.
Hi, Yutaro.
I'm glad to host this meeting today. So we have received some questions in the Q&A. So first, I'd like to ask the speaker a question. Hi, Dr. Zitu. Thank you for your presentation. You are mute. Thank you.
Yeah, sorry. Welcome.
We have learned about the differences between children and adults in pain pathways. It is a very important issue that the problem of pain in children has been identified, but not adequately addressed. What do you think is the solution to this problem?
Thank you for your pointed question. This is very important point, I think. Personally, the important thing is not to give on education for healthcare provider. I believe the continuing education and creating a new information showing platform for medical professional to share information about pediatric pain will lead to smile on children's face. Thank you.
Thank you. So next,
May I ask questions, Yutaro?
okay.
Yeah, I don't know whether this is for Dr. Kato or Dr. Igarashi, but you know, somehow children is like have a stressful and it's connected to the parents stressful, and would that interfere with our with the pain management or something like that in children? Thank you.
Thank you.
So how about Dr. Aiko?
I think, well, yeah, you're right. When we deal with patients, especially children in pain, it's quite important to build a relationship with their parent as well. If there's no trust between parent and practitioner, it makes the situation very difficult. So most of the time, I try to talk with parent as well as children, especially when parents are in difficulty, like single parenthood, or some parents are very in a very difficult situation, not only by the children's pain, but other factors as well. So we need to discuss lots of social problem with parents and build a relationship with them. Then usually we can get the trust from children as well. So it makes it all difference for the treatment of pain, I guess.
So you mean that the anxiety of the parents and the children's will interfere in how they cope with the pain?
Yes, and
Okay.
because I'm an anesthesiologist, so I have an occasion to see patient and parent before the surgery. And most of the parents are quite anxious about the pain brought by surgery. So I talked with parents as well as children about the procedure itself and how painful it is and how the pain itself will be transformed after surgery. Because, for example, after day one, it's very severe, but probably next day it is getting better. And after 3 days, maybe you can start eating or start moving. And that makes the parent and children less stressful about surgery. And I hope that that kind of talks brings a better result.
Hi.
Uh,
May I speak here?
okay.
Yeah, I agree totally your opinion, but as another problem, as based on my clinical experience, in terms of family problem or social problem, it is very difficult to find out the information. Usually, it takes much more time to get it. On the other hand, it is easier for us to focus on physical problem, but the physical problem is not a physical problem is just one of the etiology to induce pain. This is very important point, I think.
Thank you.
That's it. You're welcome.
So, Dr. Aiko, the parent and child relationship is a very important factor when considering chronic pain in children. So you also referred to it as the cream on the pancake. So I think intervention with the parent will also be important. Could you share some of your experiences with us?
Well, there are one patient who needs to have abdominal surgery, and she has existent pain because she has some, I think she has Crohn's disease or something like that. And because her pain before the surgery was really, really severe, she even couldn't sleep at night. And she spent most of the time at the toilet because she has a severe diarrhea and then abdominal pain. So both of them, parent and the child, has a high hope, quite a high hope on the surgery, and they somehow believe that the surgery resolved all kind of problem with pain. So I talked with the patient as well as the mother, and the surgery itself may brought another kind of certain pain, and actually, the child need about a half year for the treatment of pain after the surgery. But talking with the mother and father and the children, it was really like brought the situation into new stage. And after half a year, she was discharged without any chronic pain problem. She's now a nurse, so I think she doesn't have any problem of pain, and she is actually taking part in our, the medical profession to become someone who tackle with the problem of pain.
Thank you very much for providing specific example. So here is a Q&A question to Dr. Aiko. Hi, Dr. Aiko. Is there any evidence of usage of gabapentin in preventing transitional or severe acute pain into chronic pain in pediatrics?
Well, I sometimes subscribe gabapentin, but I don't think there is no effect of prevention. So if we see someone with severe pain, I sometimes prescribe gabapentin actually, but maybe it does not. How do you think about it, Dr. Jitu?
Me too. Yeah, unfortunately, gabapentin doesn't have effect to prevent like this pain, as far as I know. That's it.
Thank you. And next, for the two speakers, which age group has higher risk of chronic pain after surgery?
Ayuko, please try say.
I think around, well, I have all ages of patient with persistent pain, but the hardest is the one around 10 or between 10 to 15 maybe. Because in Japan, the time is the time that some of the children need to study harder to pass the entrance exam for schools or things like that. So besides pain, there are a lot of family issues also take place in that period.
I
That
see.
makes the situation worse, I guess.
Social matter is also important. I see. So
Yes,
next, to the speakers, what about the usage of ketamine in pain management and the conflict of its effect on developing brain? Oh.
In terms of ketamine, previously I have used ketamine for adults and pediatrics. However, of course, sometimes it's response, sometimes doesn't response. But usually we don't use regularly. But sometimes in case of CRPS, some type of CRPS is very response to ketamine, but adaptation is very limited. First of all, rehabilitation and rehabilitation is very recommended to treat CRPS to reduce fear and anxiety.
Thank you. Okay.
I agree to Dr. Jitsu. Ketamine has an effect, but the effect is quite limited. And you also have to think about its side effect as well. I sometimes use ketamine for the procedure pain control. But if you use too much ketamine, it may cause some negative effect on cognitive function. I recently prescribed a lot of, actually I am not the one, but the surgeon prescribed lots of ketamine for procedure and give it like 4 or 5 times a day. And the girl developed a short time memory loss. We noticed after several days of the ketamine administration. So in case of big children, you have to be careful about giving them a lots of dose of ketamine. I don't know about the low dose continuous ketamine administration, but you have to think about the possibility that the ketamine may affect their cognitive function.
Thank you. And the next question, how we know in children it's acute pain or chronic pain? And what's the best scoring system we can use? It's very difficult question.
Yeah, it's difficult. So if I have a child who suffer from pain, so first of all, we try to we need to continue examine sensory and motion and cognition This is very important. Usually, in case of a physician, once a physical problem is ruled out, every pain causes should be psychological, logical. This is very dangerous assessment. For a long time, we need to get to a true cause of pain in each kids. This is my opinion.
Thank you.
Well,
Yeah.
there are lots of estimating scale of pain according to the child's age. But basically, my approach is to believing whatever they say. You know, maybe it's not the pain related to injury, but they express the pain in their mind or in their situation. So whatever they say, I'll just believe in what they say. If they say it's painful, I think there is a pain, some kind of pain, maybe not physical pain, but they have some kind of pain.
That's true.
So yeah, using pain scale is quite important. Appropriate pain scale is quite important, but more than that, well, believing and taking their pain seriously is the key to treat any kind of pain in children.
Yeah, actually, can I say that? Yeah, in addition to this, in addition to Ayuko's comment, so before assessing pain causes, we need to make a good relationship between a healthcare provider and kids and parents. This is very important thing, I think.
Thank you.
You're welcome.
So there are many questions. So I will pick up to Dr. Aiko.
Yes.
How do you manage child pain that later turns into adolescent pain and young adult pain that is related to mother relationship complex?
That is very difficult question, and I can't find my answer yet. There are lots of, there's no silver bullet for this. There's no one answer that can solve the problem. And the relationship between especially daughter and mothers are really important and really make the situation better or worse. So as Dr. Jit said, building a good relationship with parent is really important for our practitioners.
Thank you. And next for Dr. Jitsu.
Right? Yes.
How long can we use morphine as the treatment for chronic pain in children?
Thank you very much. Thank you very much for a good question. This is a very important point, but unfortunately, I would say opioid is not recommended, especially in pediatric pain, because in case of chronic pain in kids, almost medication is very resistant. It's based on the result, based on evidence. So we need to know, except for medication, we need to try to reduce pain using like rehabilitation and cognition therapy. Sometimes acetaminophen is assistant as helpful. Very, very limited, I think.
Thank you.
Could you give us opinion from Ayuko?
Yeah. Well, I think I do not. I refrain from prescribing a lot of opioid to any patient, including children. And sometimes I do, but I also tell the parent and the child that this is time limited. So there's this time and this condition that I stop prescribing opioid anymore. And what I want children to learn is that the pain doesn't go away sometimes. They should live with the pain and they should find something that is more interesting than, focusing on pain. So that's why I encourage a lot to encourage kids to keep learning or doing some activity like solving puzzle or watching TV, whatever, what interests them, other than just focusing on their pain.
Thank you. So I will ask the panelists. Do the panelists have any comments?
Yutaro, can I just answer? Regarding
Yes.
parent and child pain, I mean, if a child presents with pain and you also have parent on board, so when you tell about what kind of pain it is, it's an acute or chronic pain, I personally feel that the compliance with treatment is much better. It could be even for acute pain management or chronic pain management. So once the parent knows what the child is going through, it's so much more easier. It could be psychological strategies that we suggest, like Dr. Ayuko suggested, like watching distraction or getting involved in activity. So if the parent understands the concept of chronic pain, it's much more easier to get the child on board as well. So I think this child-parent relationship is very crucial to us, and we should dwell more into it and try to get the best out of it. Thank you.
Thank you. Very helpful comments. So how about Dr. Angela?
I have the same opinion as Anu. I work in a chronic pain clinic, and a lot of the time, as Dr. Yuko says, they have to understand that it's a chronic disease, so it might not go away. And parents don't deal well with the news that it's going to be chronic and it's going to be with their kid for a very long time. So I believe that the education of the parent and the child in the same setting to help them understand how it came about, what maintains it, and how they can move forward and make things better and still have a life despite that pain is very important. And if the parent buys into it, you generally will see increased compliance with therapy and increased acceptance in the child. And if the parent doesn't, you see the opposite happen, because then what happens is they will take the kid and go look for another doctor to give them a different answer. Yeah.
Thank you. And hi, Dr. Ade. Could you give us some comments?
Yeah, I don't have many experience about the chronic pain. I usually do acute pain, so I don't have any comments for the chronic pains. Sorry.
Thank you. So next, I'd like to pick up Q&A. So to Dr. Aiko.
Yes.
How do you use WHO ladder step for pain management?
For children, no, I probably don't. I don't prescribe opioid most of the time. And yeah, no, I don't. I do kind of automated start treatment for children with pain.
Thank you. And next.
Probably I should pass this question to Dr. Zitu because he has experience with lots of kids.
Yeah, totally. I agree with you. Yeah.
Thank you.
Yeah, welcome.
And to Dr. Aiko.
Yes.
How do you manage anxiety in the post-operative period? What is your view on benzodiazepine use?
Well, I am an anesthesiologist, so I prescribe benzodiazepine like midazolam is the starter of anesthesia. But after the surgery, I don't think we need the one. You know, making anxiety less is only through interaction with patient and the parent, and actually decreasing the degree of pain. So as I told in the slide, children are quite resistant and resilient against pain. So once they understand that the pain or the most of the pain is gone, they start to go back to their normal cycle of their life. So I don't think we need benzodiazepine after surgery.
Thank you. And next will be the last question. Dr. Eko, can you give suggestions from your own practice in order to prevent chronic pain in the perioperative period?
Well, as I said in my presentation, makes them less painful after surgery is the most important key. And also make the anxiety before the surgery less and less through talk and interaction with parent and kids. And make a very good explanation, very precise explanation about the procedure and the pain brought by the procedure. And make them understand what is going to happen, 2 days or 3 days after the surgery is quite important, is my opinion.
Thank you. So I'm sorry, but now is the end of today's webinar. There are many questions. We are so sorry we cannot answer all of the questions. Sorry. I would like to thank all the speakers for this for the very, very interesting talks and the time spent preparing them. And I would like to also thank Dr. Anu and Angela as panelists for today, and also Dr. Ade for helping us with the IT support today. And also the audience for staying back with us. Without you, the webinar will not be a successful webinar. So I'd like to thank all of you. And before we say our goodbyes, we have just a few announcements. First, your feedback would be appreciated. Pediatric Pain Special Interest Group webinars will continue. We will take your opinion into account. Second, the webinar is recorded. And made available for future viewing at our ASPA website, Facebook, and YouTube. Please visit, like, and follow us. Third, our next webinar will be held in April. The topic is perioperative pain in children. Please join us again next time. Fourth, ASPA Flex webinar will be held tomorrow. The topic is neonatal anesthesia. Cases for discussion are tracheoesophageal fistula with duodenal atresia, omphalocele, and septic preemie with perforated gut. Please check at ASPA website. And finally, ASPA's annual meeting this year will be held in June in Korea. We look forward to seeing you all again. Okay, thank you very much on behalf of Dr. Zitu Aiko and all the panelists. Thank you for today's webinar.
Thank you all.
Thank you all very
Thank
much.
you all. Thank you all.
Thank you.